Hello, everyone. Welcome back to our weekly webinar series. We have Dr. Mohammad here today. He's, once he turns on his video, there he is. Your audio's off. Joining us from Cambridge in the UK, a little bit, I'm sure, better off than being in London, from what I hear. We've been partners in terms of with genetic care on the medical record side for many, many years. And asked him to join us today to share with us, first the story of why he ended up creating what he created. And it's a personal story, like many of us who've started companies falling apart, of course. And then we'll kind of, talk about some other examples of how access and why it's important and what it can create, positively, and if not, what are the risks, both ways, even in terms of, support. So Dr. Mohammad, welcome. Thank you very much for taking the time out of your busy schedule to be with us today, and introduce yourself briefly. I mean, everybody who's part of genetic care obviously knows PKB very well. But we'd love to hear, how did you get into this space? What happened? So welcome.
Sure,
thank you. And welcome, everyone.
Thank you very much. And so let me know if my audio is cutting out. At some point you were saying was cutting out, and I don't know if it was mine, but we're good. Cool. So my name is Mohammed. I'm the co-founder and CEO of Patient Care Best. To a bit more about my background, and then some of the stories that I came across. So I trained as a physician and a programmer in Cambridge. I'm originally from Bahrain. I grew up in Cambridge, and then I trained there. I then went to the States to work on healthcare IT. I'm basically a geek. I'm obsessed with computers and healthcare. And
your voice is not very clear. Your voice is getting cut. Dr. Mohammad, they're saying that your voice is not clear. It's
computers in healthcare.
Can everybody hear me clearly at least? I guess he'll come in. Can you use a different internet or a 4G?
I'm going to dial in.
Yeah. Sorry, everyone.
So, if I keep talking for a while, can you hear me better while the phone connection is loading? Or
no, it's still cut up. Yeah, it's cut up quite. Sorry, everyone, for this experience. We tested it a few days ago, but I guess there's always a first time, huh, Dr. Mohammad?
Yes, there is. My apologies.
No issues. Technology is technology. You're the one that went to the United States to be a geek. Huh?
Yes. I'm going to. Is that better without the video, by the way?
Yeah, that's already better. But you're going to connect to the phone, because we'd love to see you.
Definitely. So while it's loading the phone,
okay. Go ahead. Start telling your story, and then we'll take it from there. Go ahead, doctor.
So I think you heard I trained as a physician and programmer in the UK, and then I went to the States to write books about healthcare IT. I was a researcher. And one of those books got me really excited. So the book was about how do you give medical records to patients. So if you're the IT director of a hospital, how do you open up the medical record and make it available to your patients? And I became obsessed with that problem because I myself am a patient. I have a rare disease. And so I remember that when I see my physician, he asked me what to do. Now, as I was growing up, I assumed that my physician trusts me because of school, but it turns out it had nothing to do with that. He trusts me because I'm the only one who went to all the appointments. I'm the patient. That's what the patient ends up doing. 1 second, sorry. It's saying that I need to register to come in, but it's strange that it's not. Faisal, can you give me the dial-in from here?
Jamie? Yeah, Jamie can help you on your WhatsApp directly. So go ahead, keep sharing, and Jamie will help you.
Thank you. I noticed that my physician trusts me because I go to all the appointments. I'm the one that is the historian and the integrator. And so I began asking the IT directors why they weren't giving all the data to all the patients immediately. I could see the benefits. I could see how it helps the patient, how it helps the physicians, how it helps the organizations. And so I spent a year trying to convince them. This is back in 2007, 2008, and they weren't doing it anywhere near the speed and the scale that I wanted. And so I thought, if I want this to happen, and I really do, I need to just start a company that does this. This was back in 2008. I left the States and came back to the UK because the biggest barrier I saw initially wasn't that the patients weren't ready, they were, or the technology wasn't ready, it was, or even the physicians didn't have legitimate problems, they were all solvable. It was in the USA, there was institutional conflict around delivering this for patients. So the UK at least allowed creating an environment where the institution sees financial benefit in the patient having all the data. So that's where we started back in 2008. And really the people that we started working with were a small number of people who thought in the same way, that this was the right thing to do for patients. But it took a while to find institutions and then health economy that did that. So the big break for us was in 2015, when the whole of Northwest London, 2.4 million people, thought this was the right approach. And we now have 20% of England's population, so we have 12 million people's records delivered in this way. It's the largest system in Europe, and we have other countries using the system as well. I think the big thing for me on a personal side is just, I remember my mother bringing me up with my rare disease. So I remember, as a teenager being very embarrassed as she was with a doctor and saying to him, "You're wrong. He doesn't have what you say he has. The symptoms he's got are different to what you're saying." And going from specialist to specialist until she found the person who would correctly understand my disease and correctly diagnose me. And that was a real transformation for me when I was able to do that. What we find when we speak to patients on the ground is that many of them, especially with the rare disease, have this attitude, but also the ones who are looking after someone with long-term conditions are the ones who also understand it. So I think this is the spirit in which I met up with you, Faisal, in that you were trying to bring this attitude of ownership and looking after your health as core to everyone that you work with. And that's how we started working back in Hong Kong and work with parties that have that.
Yeah, it's empowering, right? Empowering the individual. I mean, we go into our meetings with our bankers, with our lawyers, fully prepared, but we go into seeing our doctors expecting them to be able to solve everything and to do everything for us, and we haven't done the work. Am I echoing as well, or is that you? Yeah.
I think I have my phone working now. Can you hear me, or is it echoing?
Yes, you're perfect. No, it's perfect. Okay,
my extreme apologies. You can now see my head with the bulb reflecting the light. Everything's working now. Thank you. Go ahead, sorry, Faisal.
No, so I was just saying that it's empowerment, right? And giving people also the responsibility for their own care, right? And now that you have the records and you have the access, you are taking responsibility and you come prepared rather than the illness on a practitioner obviously only knows so little, right? So go ahead, you're telling, so you saw how your experience with your mom, and then what happened?
What I find is often people are not so good at being responsible for their own health. I mean, they'd like to be, they just tend not to do it. They're extremely passionate about looking after someone they love. So for your child, for your parent, for your partner, you will really make sure you pay attention and look after things for them. Now, the problem if you're trying to look after someone that you love is often the healthcare system doesn't know how to manage giving you information or letting you help be part of the team. So a lot of the idea behind personal health records is even if you as a patient at a certain point are empowered but don't feel that responsible, you can bring in other people who will help you. Because it's the circle of care that's going to improve your health. And conversely, you know, you may have your spouse look after you and you will help look after your spouse. I do the same for my wife. We basically keep an eye on each other more than we keep an eye on ourselves. But it's part of the family, it's part of the love and the circle of care. But you can't rely on the professions to do that for you for a number of reasons. I mean, one is, at the end of the day, it's your body. You know, the difference between healthcare and aviation is that if the pilot in aviation does something wrong, they will die with the airplane. But if the surgeon does something wrong, the patient will die and the surgeon will not. So it really is on you to pay attention and to keep an eye on things. But it's also humanly impossible for a physician to know everything. I mean, not only is the full space of medical knowledge huge, but just keeping track of one patient requires a lot of effort. And really, they only have 10 minutes, 20 minutes, 30 minutes with you. I mean, the miracle of healthcare is supposed to be that you can go to your general practitioner and ask him anything. And in those 10 minutes, they're supposed to figure out what to do for you. Of course, they can't. And even as they manage you from episode to episode, they can't keep track of everything that's happened to you, everything's happening. You really do have to pay attention. And on the flip side, when you do pay attention, so for me personally, I, for example, inject myself with antibodies for my illness every week. And it used to start out that I would go to hospital for a whole day every 3 weeks. And then they taught me how to do the thing by myself for a whole day at home. And then I could inject myself for an hour every week. And it wasn't just more convenient for me that I could leave the hospital and, you know, I could travel, I could go to university. It was safer. When I'm the one injecting myself, because I live with this 8,000 hours a year without another doctor around me, I deliver better care to myself. So that you scale that up across pretty much every disease. 80% of healthcare is on conditions where the majority of what happens depends on what the patient does. You have to change your diet. You have to change your exercise. You have to check the insulin for your diabetes. You have to take the pills for HIV. The doctor might be there for your appendectomy, but for everything else, you have to do it. It's a long-term condition. It's a long-term responsibility. And so this is what we're about. It's not just that the patient has the power, but they also have to take responsibility, which I know is what you try and do with your members.
Yeah, I mean, the idea is first, if you expect, you know, to expect somebody else to know you without you knowing yourself is absolutely ludicrous, right? It's like going to a lawyer and saying, please help me structure my succession plan or my trust, and you don't even know what assets you have, right? You don't even know what's in the bucket, right? So we would never do that because that just wouldn't work. But when we're coming to the doctors, have we done, you know, have we spent the time to discover ourselves, right? To really get to know who we are, where we came from, how we got here, and looking at it from a multidimensional perspective. In this case, you're talking more from a physical realm, but I know that you also look at, you know, the mental, the emotional, and the relational. That's what we do. But 100%, right? It has to start with self, right? And again, just even when it comes to care, it's self-love and self-care in order to give the care that you mentioned to your partner, to your children, to your parents. So are you seeing that a lot of them are doing a much better job with their loved ones than themselves? You see that as a pattern?
So I see that very often. I mean, sometimes it's just because even when you are taking responsibility and looking after yourself, when things really become problematic, you are too unwell and you need the help of others, right? You're on a stretcher, you're unconscious. And so you need other people in your circle of care to look after you. But look, I mean, to take your analogy of the lawyer, that you have to know your succession plan before you talk to the lawyer. I mean, at least in the legal profession, there's no emergency lawyer, right? You don't go to a lawyer about an emergency and that lawyer has never seen you before and doesn't understand anything, and you have 10 minutes to start doing stuff for you, right? And after you leave that emergency lawyer, it's you who's got to do the things that they mentioned to you in the consultation, and you have to know what happens, and you have to look after yourself. I mean, on the family part, what we find is, because the majority of what healthcare is today is about long-term conditions, and it's about behavior change and change management. Medical schools and medical professionals are appalling at change management and behavior change. We haven't been taught, we don't know how to do it. We can tell you that you should take a pill. We can't tell you how to make sure you take the pill. We can tell you you should lose weight. We can't actually make you change weight. But you know who often does? It's your family. It's the people who are around you who love you, right? So often what we find is, the typical patient is, middle-aged male. They go to the appointment, tantrum, they just say, and the wife says, "How are you?" And he says, "Hey, I'm fine. Doctor said I was fine." And it's only when the wife sees the poster in the room that says, "You get access to your record," that she says, "Go and get your record, let me have a look." And she says, "Look, the guy's been telling you for 2 years you have to lose weight. Tomorrow we're going to change diet," right? That's behavior change. It's when people who love you know what needs to be done and start helping you do it. You're not alone, but also the professional isn't the one who's going to help you do it.
Yeah, so we're a little more proactive from that perspective, where we beg or ask or request the families to never go alone to any doctor's appointment. And we do that because of selective hearing. So I used to go when I was sick and I went to a surgeon, for example, and I went, my brother was there, my cousin was there, and my former wife was there, and we'd go in, and it was my surgery post the 20 rounds of chemo. And we all went in to talk about this surgery, and we all came out with 4 stories, right? How can you trust me? I'm the patient. How can you trust my former wife? She's very connected to me. How can you trust my brother? And how can you trust my cousin who's like my brother, right? So who do you trust of the 4, right? So we're all biased and warped, but we came back with 4 stories. So, sending someone alone we've never done it. We have, since I can remember, none of us have ever gone to a doctor alone, except for me, actually. I have a few times, but not any of the loved ones. So, that's kind of a one step ahead of what you're talking about. But of course, we're privileged. We can take time off. We're not, we're not in the space that maybe many of your patients are, right? Where they can't take the time off to be with their loved ones for every appointment.
So it's difficult to know. I mean, one of the things we try and get across is the concept of the team. So from a medical professional's perspective, the team is, the physician, the nurse, the receptionist, they're the team. And actually in the 21st century, the team, for a start, includes the patient, because the patient is now a provider of care. They're the ones injecting themselves. They're the ones taking the pills. But the team now also includes the family. They need to see everything. They need to help. And each of them has different resources. So it's not that each of the 4 of you had a story in Who Do You Believe? It's actually, I believe in the 4 of you working together as a unit. Because together as a team, you will fill in each other's gaps. You will adjust for each other's weaknesses, and you will deliver a better outcome for the patient than if it's just the patient by themselves.
And that's exactly what happened, right? We all came out, we all shared our stories, and then we collectively made a decision on whether to have one large surgery, which the doctor thought we were completely insane about, because it would have been 7 hours, versus 2 separate surgeries of 4.5 and 2.5. So he said, "You don't want me to be standing there for 7 hours. Trust me, I'll be tired." Right? Which I think he knows his body better than we do. So you're right. So some of us would want to listen to him. Some of us push back on him. So the team is the patient themselves and the family members. That's what you're saying. Okay.
All of them are motivated by the same desire for that patient to improve, but each of them did bring different skills and different. And part of what you're saying about your ability to hear is when you're the person. I personally, I filter out the bad news. because it's painful to hear, right? But if there are others around you who want me to stay alive for longer, they will say, no, but your doctor said this and you forgot about that. And we keep going in that way.
So give us some examples as to, you know, some stories where, I know you shared your own, in terms of the medical records. Like what are times, I mean, we obviously know when there's emergencies, right? So you're sitting in Bali, you're on holiday, something happens. I mean, from our experiences, you know, we are the backup in the sense that obviously the family has access, but in almost all cases, we have access as well. Of course, there's a medical, I mean, a privacy, you know, privacy side, but we're able to provide those records to the medical assistants or to the doctors, obviously on a temporary basis, which is available right through your system, so that they can know. And in addition to the records, we have our own within the records profiles, right? So yours is sitting on a portal, a genetic care portal, and so that there's summaries of historicals, right? Because in your portal, there's not as much detail in terms of the, you know, parents and their siblings, their grandparents and their siblings. So a lot of the genetic side, right? So we add all of that, and to give a big picture. So I understand in a medical emergency, the relevance. And I guess in chronic, is that what you're referring to about diabetes and people injecting themselves? I mean, where, I mean, in terms of priority, I know it's important for all of us to have it, but who are the ones at higher risk, and then middle, and then lower? Just so people can kind of, you know, the left brain people can kind of understand where they stand and put themselves in that situation.
I mean, the obvious answer is that the older you are, the more life is against you, and so your risks go up. The more conditions you have, the more complex it is. They interact with each other, and you're sicker and less able to look after yourself, and so on. But also, you know, a lot of the people who use this want to be proactive. So while they're well, what can they do to stay well? To me, the thing that I really like about it is when somebody feels empowered enough that they change how they think about their own health, their own ownership. So if I just give you some stories, so and they're really the full spectrum, right? So I remember one lady called me. Her son had recently died. Bless her. It was really sad. He was in late teens. He was very sick. She told me the thing that she liked about the system was she was able to document things about her son and share them selectively with people, because what she worried was, because her son is so ill, she worried that doctors would give up on him. That they would say, he's so sick, he's not worth treating. He's not going to be around for long, that kind of thing. And she wanted to have every doctor fight for him every time that he went to the emergency department. And then on the other hand, I remember a physician in Great Ormond Street Hospital telling me about a child who he was very sick, but she told me he was very difficult to deal with. And it's because, you know, like I know when I was a teenager who was unwell, I hated my illness. I hated everyone who reminded me of the illness. So that meant my physicians and my parents. But when he got PKB, because he could message her, he, as a child, could message her as a physician, and she would respond to him. He then began, he felt that he was now in control. And then he began paying attention, and then he began doing stuff, and it was just purely a perceptual change. She wasn't doing anything differently for him, but she was allowing him to take ownership of what was happening. I remember a university student who's got inflammatory bowel disease. Inflammatory bowel disease affects your gut, about 1 in every 150 people. Most of the time you're fine, and then suddenly you're unwell. And when you're unwell, you're really unwell, and you need to get the right treatment quickly. If you don't get it quickly enough, your gut gets so bad that you then have to have surgery. So, and it often hits working age people. So this guy was saying he almost dropped out of university when he had it, but because his physician put him on the system, he had no control. And I mean, you can imagine being in classrooms and suddenly...
Again, doctor.
Can you hear me again? Is that any better, Faisal?
Yeah, it's fine now, but it's, yeah.
Okay, sorry,
yeah,
I think,
it's better now. Yeah,
I think I'm getting too excited.
He said he was in class and he wasn't in control in the classroom.
So if you can imagine, you're in a classroom, you're with your friends at university, you're very self-conscious, and then suddenly you have to run to the bathroom, and you can't explain why, or you don't want to explain why to your students, and then it can get worse, and you disappear for days, and people are asking why, and so on. And it's an embarrassing problem, for example. So he almost dropped out, but his physician set him up on the system, and he gave him instructions in a care plan on what to do by himself, and gave him a route to escalate immediately when he needed to. And he gave him his test results real time. So he said, as soon as you get the test results, you will know before I know. And this is what you can do to look after yourself. So he then feels in control, and he stays at university, and now he's graduated and he's got a job, and so on. And the last one, I remember one of the hospitals in London, they have very sick adults. And when one of the patients got the system, he said, for the first time in my life, I feel safe enough to go on holiday. Because if he would otherwise stay within a 50-mile radius of the hospital, because he just didn't know how to explain to someone in the emergency department or how to get help. I mean, to be honest, for my first holiday from the UK, I would have gone to France. He went to Australia. I don't know why he took that bigger risk in the first time, but basically he felt free, that he can go around and travel.
Very far. Okay, 50 kilometers all the way to Australia. Okay.
All the way, right? But it's that change in abilities that this delivers, that you feel empowered because you now understand what's going to happen. You now understand what you need to do. You can travel farther and do more.
Okay, your line's not very clear, huh, Doctor?
Any better now?
Unless it's me. Anybody can put a comment in the chat box? Yeah, go ahead. It's the ability to do more. You can travel farther because you understand what's happening. You can control what's happening. So why, for example, in the United States, there's 3 major companies that control the medical records, right? What is the story behind that? Why don't you share a little bit of the background so people can understand why is there this need to control the records as an institution and forcing you to either give full access or to download when you need to share? So what's the story behind that without making it political, Dr. Mohammad?
That's fine. So it's what it basically comes down to is
Doctor, are you with us?
Healthcare system. I'm going to go back to
yeah, go ahead. The healthcare system. Go ahead.
I'm going to go back to audio. So the healthcare systems they structure themselves around making money from locking you in as a customer. That's fundamentally what it comes back to. So the 3 companies you're talking about, Epic, Allscripts, and Cerner, the healthcare systems that use them look after, at one point or another, 80% of the people in the USA. Because you might go to a physician's office that's owned by the hospital system or the hospital and the emergency department and so on. At some point, 80% of people are touched by these healthcare systems. And what they fear is that if you have your medical information,
I think we're going to have to go to audio, huh, Doctor? Maybe we go to audio because you're up and down.
Yep.
Unless everybody can hear, fine. I don't know. Maybe it's just me. Go ahead. Why don't you just go to audio until everybody tells us where we stand? So you were saying 80% of the hospitals.
80% of the hospitals, these hospitals using these systems look after 80% of the people in the USA at one point or another. Are you back to hearing me now, or is it still not working?
Yeah, no, they're saying, they're all saying they can hear. Okay, I'll put your video back on.
Okay. Cool. The host just stopped me, that's fine.
Go ahead and put your video back on. Maybe it's me then. It's just probably me. Go ahead, put your video back on, Doctor. Yeah, go ahead.
It won't let me. It says the host won't let me. It says the host has stopped me.
Okay, go ahead. I'll figure it out. I'm not.
Sure.
Go ahead, keep speaking. I'll figure this out.
You can all remember my hands and face while I'm talking. Sure. So they fear that if you're in one hospital and you get your record, you can go to another hospital. And so all their efforts at releasing the data are very much to lock you down within their institution. And the latest thing they've done when they open up, say, Epic's data into your cell phone, only do so by your phone logging into your hospital system and not logging into any other hospital's system. So it's really a lock-in approach. And if you look over the last 20 years in the USA, so one law they repealed 10 years ago was called Starkey Legislation. That was the laws that was anti-corruption. They prevented a hospital from owning a physician's office because the physician's office would refer you to the hospital, and they didn't want the hospital to own the referrer who then determined the payments, right? So they repealed that legislation 10 years ago in the USA, and the hospitals began buying up all the physicians' offices. And they then began buying up medical record systems that enforce the lock-in. So you're really locked into their referral pathways into their hospital systems, which is, I mean, on the one hand, it's un-American. You shouldn't, it's the opposite of free enterprise in the USA. But it's also the last thing you would expect from, you think it's a consumerized medical society in the USA, but actually it's cartelized in how they've organized their healthcare systems. And that's how you end up with what you're asking about. And so what we've done in the UK, and we now build 12 other territories, is that the region, the healthcare economy, realizes that the patient should be able to travel to whichever provider looks after them, and the record should be with the patient. It goes wherever the patient goes. That's the morally correct thing to do, but that's also the financially efficient thing to do if you're thinking at a geographic population health level. So we work with local governments to do that, and the rest of the world is more like the UK in trying to control healthcare costs than the USA in leaving it to the deregulated cartel approach. And so we're finding this in other territories, but that's the background. That was the reason I left the USA, basically. Fundamentally, those were the wrong incentives that meant we couldn't prove this model in the beginning.
Well, you see, so the Americans have taken a step further, right? So they're saying, okay, we're gonna take away that legislation, and we're gonna allow you to buy out the whole chain, correct? And as a result, you own the whole chain, you own the process. But now let's take a different example where, even though I don't own the chain, if I incentivize the GP to send me to a surgeon, or I incentivize the surgeon to come to the hospital and do the surgery, right, or to do a CT scan or an MRI, then also there's an incentive, which is not, like for us, we are very clear, we have no financial links to any institution, any doctor, any of that space, right? So we are black and white, but we see that commission base, right, whether it's labs, whether it's CT scans, whether it's x-rays, whether it's surgeries, still exists. Now, in the UK, does that still exist?
So in the UK, yeah, so the UK has flipped it. What they've done is they've given the budget of the procedure to the referrer. So the referrer doesn't have an incentive to send you to an unnecessary operation, but they do have an incentive to not send you to a necessary operation, because it's coming out of their budget if you consume healthcare. So fundamentally, there's always going to be conflicts. And that's why you need your independent advocate, whether it's your family or someone like Geneticare. I mean, I'll give you another example. So in 2008, if you want to see behavior in the market, in Berlin, six hotels, got rid of their 5-star rating. They just got rid of the stars, including the Hilton in Berlin. And the reason they did that is that in 2008, German law changed that pharmaceutical companies can no longer, when they pay for training for the physicians, they can no longer pay for unnecessarily luxurious facilities to do that, because that would count as a bribe, right? So you're teaching a physician about the new drug, and it's in a resort, right? So this was worth so much money to the Hilton and 5 other 5-star hotels in Berlin that they got rid of their stars. By the way, they continued to be luxurious. They just got rid of their 5-star label, so it wouldn't count as unnecessarily luxurious, right? So this is the kind of stuff that's going on all the time, because healthcare is a business, everything is a business.
So they,
but it's
so
not
they got
a
deranked.
business.
So it's just, okay.
No, I assure you, their rank remained. Everyone knew they were 5-star, but just officially,
Yeah, I'm saying, yeah, it means they took out they didn't apply for those stars anymore.
Correct. And it's worth so much money to them that they would let go of something so prestigious. They were having so many of these conferences happen there. So this is happening all the time in healthcare. It's a business like any business, but it's not transparent like any business, which is why you need a navigator, an advocate, and you need to pay attention and take control of what's happening.
Okay, but that's the NHS, right? What about in the private sector? How does the private sector operate? Does it operate like Hong Kong, where there is a sharing, a fee sharing, or it's not in the private sector in the UK?
So the private sector is primarily fee for service. So you come for an appointment, you pay a fee. You have an operation, you pay a fee. And a component of it may be reimbursed by your private insurance company, or you pay the whole thing out of pocket. So I think it's much more like in Hong Kong, but it's a much smaller sector as a percentage of the economy than it is in Hong Kong.
So if we had a crystal ball, you had a crystal ball and you could pull off anything you wanted in terms of how you would love to see medical records and the healthcare system be connected, right? And then let's bring in all the wearables, right? Because obviously the system that you have has all these wearables and the data, and they're linked to all these wearables, right? So if you had, and you said, okay, I want to create this optimal level of advocate, okay, whether it's Genetica or somebody else, that's fine. Bringing the team spirit, right, which we say always go in more than one person to the doctor, right, with the medical record access and the living and the day-to-day wearable data, right? Are those the 4 pieces, or are there more?
So I think the final piece is the regulator putting teeth on some of those things you've been describing. So the data portability and availability, it does operate in certain markets, but fundamentally the regulators at national level will start saying, I can't have my citizens not have this. I mean, we're seeing this in different parts of continental Europe, which have private systems like the Netherlands and in Germany. They're still figuring out the pieces, but you can see the direction of travel is that the national regulator will say, as part of being a licensed medical provider, you must make your data digitally available, and it must go with the citizen, not with the institution. So that's good. That's the long term for most of us in the world. The interesting thing for me is, now that you've liberated the data, now that you have data liquidity, what happens? If I give you a simple example, so in Oxford, they're using this for a research program around patients with treatment-resistant depression. There's a new drug, people who have been depressed for years, nothing's worked, you give them the drug and suddenly they completely change in a week. It's miraculous, but it's also dangerous, because they can be addicted, and there's other things you have to guard against. So you want to do research about it. One of the things they added into the research mix is put on a Fitbit, because that tracks your sleep cycle. Now, what does the GP medical record or the hospital medical record have about your sleep? Did you sleep well? Yes or no? That's their sleep record of you, right? I have 6 months of data about you every day. When did you wake up? When did you go to sleep? So how did that work as a measure of your insomnia from your depression, or your oversleeping from your depression? It completely changes the conversation, right, about how well this drug is working and what other problems it might be causing. And it needs a computer to analyze, to look at the data sets if you measure something every second, that's 31 million measurements every year for a patient, right? And if you have 1,000 people or 1 million people, that's a huge number of measurements. You need a computer to analyze that. But the understanding you will get is much greater than any speed of research in the past. So all that is possible when the health economy becomes digital, and all the trends are towards that. So to me, that's the real exciting, that's the real renaissance that's coming in improving the quality of healthcare.
So that means you would recommend, I mean, we're now in the process of providing, you know, Garmin watches to a select number of families in order to have that trackable. You know, it's a much more better product than obviously what's the basic watches that are out there. So you would encourage everybody to wear a wearable in order to help the physician with their care? Is that what I hear you saying?
So at the moment, the physicians don't know what to do with the information from your Garmin. Okay. But the research is building up. But in the meantime, Garmin's goal is, you know, what does it say? Beat yesterday, right? That's what they're trying to motivate you to do. It's the behavior change by the gamification of exercise. That's the real value. It's not that the physician knows what to do. It's that if you follow the game, you need to go to a physician less than later, right? If it can get you exercising, that's huge. And to me, that's the really interesting part from the consumer side. But in the meantime, as we connect those devices to PKB and institution begin doing research on them, they begin detecting things. I mean, it's one thing to say, you know, my Garmin picked up that my heart rate is irregular. And so the physician might say it's atrial fibrillation. We don't know how reliable that is at the moment at the watch level. It's a new data set. But it's also separately really interesting that the Garmin has picked up that you haven't walked in a week, and that you're not wearing the Garmin for a week, right? Something's happened in your lifestyle. And often that's the predictor of a few months later, something bad is going to happen. Not because a biological event happened in that week, but a lifestyle change has happened in that week. And if we don't figure out what it is and get on top of it, you'll be in the emergency department in 6 months from everything else that followed downstream. Okay,
so basically the wearable, whether it's the Garmin watch or whatever it may be, is actually a feedback loop that we're getting. So it's more about the behavioral change, not necessarily about the data, right? Because what happens is a lot of people have become very fixated on that data, right? Oh, I didn't sleep so well. And then they start getting anxiety because I got less REM sleep and less deep sleep and, you know, so the thing is, it's how much data is enough. So it's really about trends, right? It's like saying, I'm going to look at the data of my company and sales on a day-to-day basis versus a weekly basis versus a monthly basis, right? So it's the trends that we're looking for, not the data points per se of that particular day, correct? No, I just want everybody to hear it because, I mean, you're in the space, right? So it's because when I speak to GPs, they say 95% of the patients don't listen to stop smoking, lose weight, you know, the behavioral changes they're asking. 5% do, right? Which is pretty pathetic, right? That's a pretty pathetic number.
I mean, who doesn't know right now that smoking kills, right? And I mean, you know the joke, right? I read that smoking kills, so I quit reading, right? That's really what's happening with people. But if you look at Omron, the Japanese company, they make 40% of the world's blood pressure cuffs. So they started in the 1980s in a Japanese village that had quite high health outcomes, and they were trying to figure out why. And they were the first to put blood pressure cuffs in the hands of consumers. And everyone told them from the medical side that was stupid. And everyone told them from the commercial side, there is no market here, it is stupid. What they documented was, first of all, the blood pressure taken at home. And, you know, they make good Japanese high quality instruments, right? This is not Fitbit quality analysis. It's more like a Garmin, it's Japanese quality. The accuracy of the blood pressure measurement was higher at home because the patient was doing it more frequently, so they're less anxious every time it was taken. So it wasn't a big stress that the doctor is taking the blood pressure. I'm just doing it every day. It's normal. Okay. And then they found that the feedback cycle in changing the blood pressure medication increased if the physician has multiple measurements about you in between appointments. Because what happens is if they take the blood pressure, they say it's high or it's low, come back in 3 months, they take it and say, well, not in the right direction, but let's come back again in 3 months. But if I can say to you, look, here's my 12 weeks of measurements, You know, this is consistently not going the right direction. Let's change the pills. And so it's the trend that matters. It's the feedback cycle that matters, not the individual data points that matter.
So let's take, okay, there's a number of people on the call who are fairly healthy. Okay, they don't necessarily need all these things that you're referring to, right? In terms of whether they need to check their blood pressure. What should be, let's say, the 4 or 5 things that they should kind of pay attention to? And I'll give you my feedback from our side. What are the 4 or 5 things you would say are relevant?
In terms of medical records and looking after your health, for example?
No, let's say first the wearable side, right? So what's important?
Oh, sorry.
Is it the sleep? Is it the heart? Well, heart variability they're not going to be able to see, but they can at least understand their heart rate, blood pressure, oxygen level, what movement, what are the 4 or 5 elements, whether from priority wise or important wise or just generally?
I think activity is the most important one. Not so much that 10,000 steps matters and 9,000 don't. It's just that anything that gives you a consistent increase in your activity, biking, walking, exercise is just good for you. Find a habit and have the wearable motivate you to do it. As a baseline, as you get older, blood pressure is important. But the other vital signs on the market for wellness, they're not that important. And weight, sorry, is the last one. So if you do your exercise and monitor your weight and know what ranges your weight should be targeting, that's good for healthy habits. Sleep is useful to know about, but not so much, it told me I slept for 4 hours yesterday. I need to get to 4 hours, 10 minutes. It's more, you just want to, it gets you into a mindful stage about, am I putting in place the right habits so I get to sleep and rest correctly? Yes. That's really the feedback cycle we want. We don't want you to be anxious about your sleep. We want you to get everything to get rid of anxiety in your day so that you get to your night and you're sleeping well. There are other wearables that are medical devices rather than wearable wellness devices. You'll get those from your physician, but for having a healthcare episode when you want to be looking at your oxygen saturations and so on. But I'd focus on anything that gets you moving.
Okay. Yeah, because a lot of people, there's sleep is the one, right? Without rest and recovery, it's not going to be, your nutrition is compromised, your movement is compromised. So we focus on sleep. I understand what you're saying. It's not about just the sleep and the hours. It's about the environment and the behaviors that are around that, right? To get you into a state where you can have that quality of sleep. And that is what we need to focus on, right? That's what you're saying.
Sleep is not just the cause of stress. It's often a symptom of stress.
Yes.
So you want to get into a virtuous cycle where you're reducing the stress to improve the sleep, to improve the stress, and so on.
Yeah. All right. And now in terms of medical records, what are the key medical records that, there's some people who are not part of the PKB and not part of genetic care that are that are watching and going to be watching. What are the key medical records they should keep in whatever form, right? That are baseline and just to be safe. What would you recommend?
So you need a 1-page summary at the very minimum of your diagnoses, fully spelled out by a physician. So not, I've got diabetes, but I have diabetes mellitus type 1, for example. And your medications, again, fully spelled out, including the liquid dose. Not, I take the blue pill twice a day, but the exact name of the pill, the exact dose, generic, trade name, everything, because I use the generic and the trade name because you may be in an emergency department in a new country, which has a different trade name than the generic name. So get those. They're the most important determinants of safe care for you when you arrive in the emergency department. They're often hard to get, and in an emergency, you may be too sick to give them correctly and accurately. Beyond that, what I would say is every time you're with a physician, before the appointment, decide what you want to achieve, what your goals are, and bring them to the appointment. And obviously, your physician will also have some goals you haven't thought of, so listen carefully to what they say. But the 3 questions I ask about everything are, what are we doing? Why are we doing it? And what happens if I don't do it? That gets you to buy into, okay, this is what I need to pay attention to. And then before you've left the room, ask them for a plan of care. So, okay, when I leave you, who's going to do what? And most of it's going to fall on me, the patient. So I just need, yes, you've told me to take this medication, but just to spell this out, do I take it before the meal? Is it okay if I have alcohol? Just the full details. Should I be booking an appointment with you in 3 months? Should I be getting a test result before my appointment? And then what do I do in different situations? So what's the normal thing for me to do? What do I do when things are not going well? And when do I need to contact you urgently? So do a plan of care. So if you want a project management kind of, if you're onto Gantt charts, the slogan is those who fail to care plan to fail care. So you need to get a plan with your doc and make them spend 2 minutes with you going through that. They're not used to it. So you all have to say, I'm sorry, doc, and be as apologetic as it takes to get through this. Say, sorry, doc, I forget stuff, but I really want to make sure I do what you've told me to do. Can I just write it down while you're talking? And just, they will wait for you. Spend your 2 minutes, write it down. And then once you're happy that you understand it, then you can leave the room. That's how you basically record for yourself in advance what you want to achieve, and then record at the end of the appointment what you're going to do next, especially the things that are your job.
Okay, perfect. Yeah, I mean, we provide Q&A and a structure for every medical appointment, but that really puts it in a beautiful, very simple manner. Now, if I'm going for a regular checkup, what are the variables maybe I should take with me in terms of these data points that we talked about that the wearables are providing? Should I take any of that with me? Should I print it out? Should I have it? What should I do? I mean, I'm not diabetic. I'm not, I don't have, blood pressure issues or heart issues or any of those things. I'm just going in, I'm whatever, 40s, 50s, I'm going for a checkup. I'm going for we always joke around, right? It's for the balance sheet. It's that one photo. So I have the photo for the day 365 and the other 364, God will take care of me, right? So if I'm that type of person, which none of our families are able to do because we will, nudge until they don't do that. But what other variables should I take with me? What should I take with me? Should I take the sleep information, the movement? Should I take my nutrition? What should I take? Just to kind of make the experience a lot more valuable for my annual screening.
So if you can do exercise and nutrition, that's the most valuable, because the other metrics, if necessary, the physician can take them and they can initiate them as well. The next one is cardiovascular things, which is basically your blood pressure and your weight as the most important ones. Sleep is useful just for you to get some objective metric around the symptomatic feelings you have. So I feel I'm not sleeping well, for example. Let me show you some measurements I've taken. But it's not that, doc, here's a 10-page printout of my sleep cycle, you can diagnose me now. It's not like that. Yeah. It's just more of a numeric backup for a complaint you may have. But the diet and the honest diet and exercise is the most valuable thing you can bring to that consultation, because then you can say, okay, this is where I'm at. What do I need to do? If there have been any blood tests in the past or any other interaction you've had with anybody else, bring those as well. Those biometrics are important to figure out what's a trend, what's a snapshot, and it helps so much with the diagnostic process for your physician if they come into it knowing what it's been like for the last 6 months or a year for you.
And, in our case, we look at health beyond the physical. So we're looking at the mental state, the emotional state, and the relational state. Correct. So now we encourage and share episodes, triggers, events that are going on for maybe changes in nutrition, changes in weight, changes in movement, changes in quality of sleep. Do you see that more and more as becoming more normal? That, when I remember, if I go to an orthopedic and I go to the appointment, at the end of the appointment, he will assess me, but then he'll say, Feisal, get your house in order, without me even sharing, because he knows or she knows that these are symptoms. Now, do you feel that that is becoming more of a common situation or not? Because I mean, we are surrounded by people like that, but we're not your normal, you know, we're not dealing with the average doctor. What are you seeing in that space?
It's definitely changing, but you can do a lot to help your physicians. I mean, the joke about the orthopedic physician used to be, you know, doctor, it hurts when I do this. Well, then don't do it then, right? So it's very short term. Really, if we can go back to what happened a week or a month before the pain, and it's not that, you know, I was playing golf and I something, it's actually something happened in my relationship, which then led to me not exercising, which then led to me, and so on. It's all these things up front. So the apps I see now that allow you to plot variables against time. So you can see that, you know, when I do this, that happens. If you can bring that into the consultation with the physician, figure out what's going on, especially because the easiest thing for them to drill down is biological, and the hardest thing for them to figure out is the behavioral, because that's so historical and then they don't see you. And if they go down the path of the biological, behavioral, they'll harm you from the treatment for they'll miss out on the underlying problem, which is the behavioral. So you need to support them by giving, and it's now possible to bring that information, whereas, you know, 10 years ago with a piece of paper, it's difficult to show that information to your physician.
Okay, so you're saying that physicians are more open, it's being encouraged. I mean, because it makes logical sense to you and me, but unfortunately, a lot of time people say, we only have 10 minutes, what do we do? Our physicians obviously are spending 30, 45 minutes, 1 hour, whatever it takes, but the average, you know, it's a machine that's running. So, okay, we've got 3 more minutes.
It's a learning process for both sides. It's a learning process for both sides right now. The physicians and the patients are learning new habits.
Yeah. So we've got 3 more minutes. Dr. Mohammad, is there, I mean, anything else you'd like to share? And then, of course, we'd love to have some closing remarks from you to be able to, you know, remember what are the key elements that you'd like to reinforce or something new. Up to you.
I just want to emphasize again, so for me, you know, the 20th century was about advances from what the physician can do. The 21st century, so for your pneumonia, for your broken leg, the 21st century is about advances in what you, the citizen, can do. It's long-term conditions, and there's a lot more of them because, frankly, the miracles of healthcare have delivered. People are living, they don't die from cancer anymore, they don't die from diabetes anymore. So we now have people who are living with all these things. But then that means they have to learn what to do to live with these things. Yeah. And on the flip side, the technology is there for you to look after yourself more. There's devices, there's apps, there's people like Genetica who are there, who think holistically and support you. And so it's about being aware that exists and need to take charge of it and make use of it. But that's the next increase in longevity and quality of life. It's going to be looking after your body with your team.
Exactly, and Patient Knows Best helps create that team and access, right? I mean, to expand not just the medical side, but the family, including the person themselves. So perfect. Thank you very much, Dr. Mohammad. Thank you. We really, really appreciate all the sharing, even though...
I'm grateful for your patience, audio. Thank you for the time
No,
today.
Sorry. Maybe it was mine. I actually moved locations. I'm in the same place, but I moved locations. Maybe it was me not able to hear either. So thank you very much, Doctor. Thank you, everyone, for joining us. We've been running webinars every week, initially 3 times a week, and then for the first 5 weeks, and then 1 every week. We're actually going to take a break next week, next Wednesday, and resume on the 28th. You know, everybody will get a chance to, we'll send again the link to be able to look at some of the previous webinars. And if there's anything that, anything that you like to share, Dr. Mohammad, with them when we send them the recording in terms of links or, you know, or basic things, we'd be more than happy to share that with everyone. Okay, so thank you very much, everyone. Thank you, and see you in 2 weeks. Thank you very much, Doctor.
Wonderful day. Thank you.
Thank you.
Bye.